Hello, I'm Mirvat Alasnag with Khaled Al-Shaibi here in Madrid for ESC Congress, and this is the final day, the conclusion of the ESC Congress. I think things slightly started to slow down today, Khaled. Nevertheless, there's still some fantastic, robust data. You want to start us off with one of yours?
Sure. Now, as we all know, the mortality of myocardial infarction has been steadily declining over the past decade or so, but more recently it seems to have flattened out, and we recognize that part of this may be the more aggressive antithrombotic regimens that we use now lead to a higher incidence of upper GI bleeding in these patients long term. So this study, the cluster randomized crossover HELP MI SWEDEHEART trial, aimed to see whether a strategy of H. pylori screening for all comers admitted with an acute MI and subsequent eradication compared to usual care would affect outcomes or the incidence of upper GI bleeding in follow-up. So the primary endpoint of this study was upper GI bleeding. They also looked at a variety of secondary endpoints, including all-cause death, MI, stroke. It was very simple inclusion criteria. All you needed to be was over the age of 18, Swedish nationality, and have been discharged alive following a acute MI, STEMI and non-STEMI. There were no exclusion criteria. Over 18,000 patients were enrolled. 37% had STEMIs, 43% had non-STEMIs, and 84% had a revascularization with PCI. The primary endpoint of upper GI bleed occurred with 4.6% of those with usual care and 4.1% in those who had H. pylori screening and eradication. That was a relative risk reduction of 10% that did not reach statistical significance. But what is important, a subgroup analysis demonstrated there was a heterogeneity in treatment effect. And apparently patients who had baseline anemia on admission or chronic kidney disease seemed to benefit from H. pylori screening and subsequent eradication. So even though the study was negative in the general population, there may be a role for this strategy in patients at higher risk for bleeding, those essentially with anemia or chronic kidney disease. I thought this was interesting and may actually impact care.
Yeah. So just a slight, shift here. We didn't talk much about some of the surgical data, but this was fairly relevant and addresses honestly a common problem that we deal with, which is patients post-CABG. What is the ideal antiplatelet regimen? This was the TACSI trial. It evaluated dual antiplatelet versus single antiplatelet therapy in those who have undergone coronary artery bypass grafting and had previous acute coronary syndrome. So this was an open-label, investigator-initiated randomized trial that was done in the 22 Nordic centers. And they followed the patients for 12 months. They were randomized to either ticagrelor and aspirin or aspirin alone. And they looked at a primary efficacy endpoint, which was a composite of all-cause death, rehospitalization for myocardial infarction, stroke, or repeat revascularization. And then there was also a primary safety endpoint, which was a major bleeding. So for the primary efficacy endpoint, the hazard ratio was 1.06. And for the hazard ratio for the primary safety endpoint, it was 2.5 with early separation. The net adverse outcomes had a hazard ratio was 1.45. So really the key messages that we take from here is that DAPT with ticagrelor and aspirin is not more effective than aspirin alone in this subset of patients. In fact, there's probably a risk of major bleeding in these patients in whom we continue dual antiplatelet for 12 months post-CABG. Now, the issue is this will impact guidelines because when we review the current guidelines for post-CABG, it actually recommends 6 to 12 months of dual antiplatelet in patients who have a high ischemic risk or have had a prior acute coronary syndrome. So I'm sure this is going to be an impactful trial that will bring change. The trialists have also told us that they intend to follow up these patients for 10 years. And so we are going to have some long-term data, and I'm sure this is going to impact us. I know you had another trial as well, Khaled. You want to talk to us there?
Yeah, now this one may not be applicable to Europe, but it is an important trial. I think that's the My Heart, Your Heart randomized control trial. Now, it's a trial that attempted to prove non-inferiority of reconditioned pacemakers versus new pacemakers in low-income countries where there is inequality in access and access problems because of the cost of these devices, especially. And here the primary endpoint between the two groups, so that is those that have received a reconditioned pacemaker versus those who received a new pacemaker, was freedom from procedure-related infection at 12 months. And the secondary endpoint was freedom from pacemaker software or hardware malfunction or unexplained death at 12 months. Now, the patient inclusion criteria, patients had to have a class 1 indication for pacing. In fact, 80% of the patients enrolled had complete heart block as the indication, while 20% had sick sinus syndrome as indication for pacing. And the other inclusion criteria, they had no financial means of acquiring a pacemaker. So these were the patient exclusion criteria. They excluded patients with very poor EFs or had active infection, dialysis, or very short life expectancy. The 12 months results were as follows. The primary endpoint, which was infection, it was seen in 2.8% of patients who received a new pacemaker and in 1.4% of patients who received a reprocessed pacemaker. So the non-inferiority was met clearly from an infectious standpoint. There was no penalty to be paid for using a reconditioned pacemaker. Obviously, this has huge implications for this sort of approach in low and middle income countries where cost is an issue. As far as device malfunction, they looked at lead dislodgement, pacemaker removal, and death. Now, although numerically they were higher in the reprocessed pacemakers, this did not reach statistical significance in any of those parameters. And in fact, all the deaths that occurred were non-cardiac in etiology. So again, I think this is an important study that opens the doorway potentially for reprocessed high-cost items to be made available or in lower income countries. Obviously, there are regulatory issues that need to be addressed, but certainly I think this is very encouraging and may open avenues to make these expensive devices available in deprived areas.
Very interesting to get input from the FDA representatives on this particular trial. I do think it may change a lot. Still continuing with the surgeons, this is another trial that I think was interesting in concept, although, even before listening to the results, I kind of knew where it was going to go, as I'm sure you did. So this was a randomized trial, evolocumab, for patients who had saphenous vein grafts following coronary artery bypass grafting. So this is the NEWTON-CABG CardioLink 5 trial, and it's published simultaneously in The Lancet. This is an international randomized trial that looked at placebo-controlled versus early addition of PCSK9 inhibitor during hospitalization in addition to statin therapy within days of the coronary artery bypass grafting. And they were hoping to see whether it would improve graft patency, specifically saphenous vein graft patency, because as we all know, SVG graft patency remains an issue. And they actually looked at different markers. So they looked at 50% stenosis of the saphenous vein graft, 100% occlusion, and then more than one vein graft occlusion. And they looked at all these three categories. And the patients, evolocumab was able to, they also wanted to look at whether evolocumab was able to reduce LDL-C by 50% or more following the surgery. So interestingly, yes, as early as 3 months, they did see an LDL-C reduction in the arm that received PCSK9 inhibitor. In fact, it reached up to 65%, and it was sustained throughout the duration of the trial up to 24 months. However, the veins continued to fail. And in fact, there was a slight numerical increase in the number of failed grafts, saphenous vein grafts, in the evolocumab arm. So despite improvements in surgical techniques, despite aggressive LDL reduction, you still saw 20% failure at 2 years of these saphenous vein grafts. So really, when you add it, it doesn't change the outcome. It doesn't prevent occlusion, doesn't improve patency, and we kind of all knew that. It was a large trial. I think it was important that they explored it and addressed vein graft failure. But as the researchers themselves put it, it's important that we underpin the biological differences in the saphenous vein graft that render it more vulnerable to occlusion post-CABG. At the end of the day, it's a very different system from an arterial graft that that at least they gave it a shot.
I'm not surprised at all by the result. I think vein graft patency is much more a function of distal runoff, of the quality of your target vessels. And then again, if edalucumab or liquid lowering is going to reduce event rates, you take it to reduce them in the native circulation, atherosclerosis in the native vessel. The surgical advantage usually is that it doesn't matter what happens in the native artery, the bypass is distal. So that's one of the advantages over PCI. So I'm really not surprised at all by the results. That's interesting.
Well, thank you, everybody, for tuning in. ESC 2025. It's been an exciting 4 days. We heard about the updates and the guidelines. We heard a lot about antiplatelet trials. We've heard about heart failure trials, and most certainly some, potpourri of trials today, from the surgeons to H. pylori and reprocessed devices. So thank you for watching.